So coming to this, I think this course is intended for the entry-level spine surgeons as well as the residents and trainees. So the main purpose of this talk is to make them conversant with the cervical lateral mass screw fixation.
Yeah, absolutely.
And
this is a basic course, and I mean, you are a part of the faculty for all the courses that we have done. So it's just the same on an online format.
Yeah, so I do not have any disclosures, and the only purpose of this talk is for the residents and fellows to know how to safely put a cervical lateral mass screw. No other objective rather than this. So cervical lateral mass screw is definitely the workhorse for subaxial cervical spine fixation, and the most common indication is the degenerative multi-level cervical spondylotic myelopathies, as well as posterior compression by ligamentum flavum or an OPLL, which is multi-segmental. So we prefer to do a posterior approach, and in that, obviously, if fixation is required, then the lateral mass screw is the preferred choice. Other than that, at times there are tumors like aneurysmal bone cyst, giant cell tumor, plasmacytoma, tuberculosis, as Dr. Pankaj said. At times they are involving the entire cervical vertebral body. Then you may have to fix them anteriorly as well as posteriorly. So lateral mass screw comes into picture in all such cases. Again, the treatment of facet joint dislocation, if it's a 360-degree injury, many surgeons prefer to do it anterior as well as posterior, because biomechanically it is the most stable fixation. So a variety of conditions in subaxial spine requires lateral mass fixation. So coming to the anatomy, what is actually the lateral mass? It is actually a block of the bone between the superior and inferior articular process. And as you can see, this quadrangle is the lateral mass. So we are not concentrating on C1, C2. We are just concentrating on the subaxial cervical spine. So between this facet joint above and below, this block of bone in the vertical extent and the horizontally from the lamina facet junction to the lateral edge. So this quadrangle is the lateral mass, and we have to safely put a screw inside so that it serves as an anchor to fix the rod. And coming to the relevant anatomy, what all structures are important here are actually the most dreaded is the vertebral artery, and where the vertebral artery is actually runs in front of the lateral masses. So if you tend to put a screw straight ahead, here you may go into the foramen transversarium. So we'll see it in the next slide in the axial section where actually it is. So in lateral mass, usually a lateral trajectory is preferred. So you will start somewhere from the middle, servo medial to the midline and go laterally. So that will avoid the vertebral artery. So this is one important thing. And while doing exposure, which is the standard midline exposure, we have to respect the midline as in any posterior midline exposure in the entire spine, and use the intermuscular plane between the both sides muscles and do a subperiosteal dissection. And at the end of the construct, you should avoid damaging the facet capsule, as is true for all posterior spine exposures. So you avoid damaging the facet capsule above and below so that there is no degeneration there. So this is actually the lateral mass. So coming to the next slide, this is the facet joint. This is all the lateral mass, this quadrangular bone, because this quadrangle has to be defined anatomically when we are exposing posteriorly, because we have to divide this into 4 quadrants to safely put the lateral mass screw. Then this is the axial cut which I was telling. This block of bone in the CT scan is the lateral mass, and this is the vertebral artery foramen transversarium. So that is why we direct our screw something like this, around 20 to 25 degree lateral trajectory, so that it doesn't injure the vertebral artery. So this is the intended position of our lateral mass screw, and this is the foramen transversal. In the same cut, you can also see the cervical pedicle. So pedicle is the portion which connects the body with the posterior elements, and this portion is the cervical pedicle. So if you wish to put a pedicle screw, we have to go more. The entry point will be lateral, and the medial angulation will be higher compared to the lateral angulation and the medial starting point in case of a lateral mass screw. So the standard position, prone and a few degrees of flexion or a bit neutral. There is, you can apply tongs to stabilize the spine, may use microscope, may or may not use. It's usually not required. It even can be done with naked eye. And this is the standard midline exposure from the inion to the C7. C2 spinous process and C7 are usually palpable on deep palpation, and you can use it as a guide to expose the midline. Then, as I said, the intermuscular pain and subperiosteal dissection to reduce bleeding, to expose the entire spine. Then, obviously, don't go within the muscle because there can be troublesome bleeding. Just follow the facial planes to reach the spinous process and then do a subperiosteal dissection. So this is what you will get after exposure, and you have to go till the lateral edge because you have to define that quadrangular block and then to decide the entry point. So if you do a suboptimal exposure, you may end up putting the starting point will be pretty medial, so and the lateral mass can break. So it's better to expose the entire block of bone. And there are various entry points described in literature by McGill, Roy Camille, Anderson, and so many techniques. But I'll suggest the beginners to just follow one simple reproducible technique and which gives success in most of the cases. And this can be used as a salvage at times. So most commonly used technique which I use is the modified McGill technique. I'll just show you just a brief recapitulation of the anatomy. This is the lateral mass. This is the vertebral artery. We have to go lateral, and the craniocaudal trajectory is actually we are going cranial to have the more purchase in the lateral mass rather than going straight. If you are going straight, the screw length will definitely be lesser. So this is the ideal trajectory, and this trajectory is actually parallel to the facet joints. So if you tend to use C-arm in initial cases, then you should be parallel to your facet joints above and below, or a small pen field can be kept in the superior facet joint to guide your craniocaudal trajectory. And the mediolateral is around 20-25 degree lateral. And if properly in anatomical position, the as I said, the craniocaudal trajectory will be parallel to the facet joint above and below. The mediolateral trajectory will actually be guided by the direction of your lamina. So when you do put your probe, it will somehow touch your spinous process of the inferior vertebra. So that will also guide your optimal lateral trajectory. This is what I was telling. This one simple reproducible technique is the entry point which I take and which is advisable. You divide this quadrangular block of bone into 4 equal parts by a vertical as well as a horizontal line. This is the center of the lateral mass. You start 1 millimeter below and medial to this point. So this is your entry point. Do your initial starting point with a awl or a bird, and then put the screw in 20 degree lateral and 20 degree cranial direction. So 1-1-20-20. This is the acronym for this. So 1 millimeter below and medial, and 20 degree cranial as well as lateral. That will avoid the vertebral artery, the nerve, exiting nerve root and everything, and you will have good purchase. Usually it is advisable to have bicortical purchase in the cervical lateral mass. So when I go to the video, I'll show you. You have to probe it, then you will get a feel that it's bicortical, and then do it. Put the screw. So this technique works in most of the patients, and usually doesn't pose a problem, except in small kids. If there is some breakage or something, the first thing, you can just skip one level and go to the other level. So otherwise, most of the times this works to satisfaction. So you need not worry about. However, if there is a breakage and you do not have an anchor point, or you feel that extending is not correct, then you just change the. You use another method, which is described. Like we are using Magel, you can use Ann method or Anderson method. Put a shorter screw in the straight direction. But most of the time, skipping one level is a better option. So I'll just go through a small video. So this is a 63-year-old male, cervical spondylotic myelopathy. He was operated for a single level C3, C4 SCDF years back, but he has some residual posterior compression also. So we plan to do a C3, C4 laminectomy and fusion. As you can see, this is the block of the bone which we said, and the entry point 1 millimeter below and medial. And after the starting point, we use a tab.
एक बार just orient again, क्योंकि लोगों को पता नहीं होगा cranial कौन सा, caudal कौन सा, medial lateral. एक बार stop करके फिर से orient करो.
Yeah, basically this is the cranial and the caudal, and obviously this is the midline, this is the lateral position. So we have reached till the lateral aspect of the lateral mass on both sides, and now we divided it by a vertical line and a horizontal line into 4 parts, and below the center of the lateral mass, 1 millimeter below and medial, is this entry point. Am I clear? This is the cranial, caudal, midline, lateral. This is the lateral mass, quadrangular block of bone. This is the lower lateral mass, C4 lateral mass. This is on this side and this is on this side. So we are just started with the owl, and then we put a drill up to 12 mm or 14 mm drill. And we can, after that, after drilling, we tap it, feel it with the probe, whether it's bicortical or not, and put a screw which is usually 12 to 14 mm length and 3.5 meter diameter. This is what the usual adult lateral masses take, and usually polyaxial screws, so that we can manipulate the screw heads in case of problem. So after all these steps which I just described, we put the screw. Now again, I'm just stopping. The technique, if you put directly laterally, the chances that this lateral portion may break is higher. So what I usually do is I put the screw for initial 2 or 3 threads straight vertical. So you can see in the next screw what I actually mean. Once it engages in the bone, then I change the directory to 20-degree lateral or cranial. So you just first have to engage the screw. Otherwise, if you put directly laterally in the same trajectory like this, then the chances of breakage are higher. So just going ahead, what I mean to say. So first straight, and now I'm changing. Now I'll change. Yeah, this is what I meant to say. Then I change the direction. Similarly here also. Engage the screw and change the direction. Once all the screws are put, in case of decompression, you first put the screw and then decompress. So here I'm planning to do a C3, C4 laminectomy. The cut is at the lamina facet junction, and this is an ultrasonic scalpel, which causes less bone loss and as well as blood loss. As you can see, compared to the drill, it's better, and it also guards the dura. And this is the drill. You can see the loss of bone here, because the same bone can be used for the posterolateral fusion. So the ultrasonic scalpel is better in this respect. And once we decompress, we remove the lamina, do not enter inside the spinal canal because it is already very much compromised. So once we do decompression and hemostasis by using bone wax, remove this ligamentum flavum as well as the epidural fat and do hemostasis. Now, before putting rod, you just cover the exposed dura with some cottonoid so that in case there is a slippage inadvertent, your cord is protected. And these are the lordotic rods which we bend as per the curvature of the spine which is required. And then put the final tightening. And this can be all done in a multi-segmental level also at multiple levels. And this is the post-op X-ray. So the position is, as you can see, the position was, even in the X-ray, you could have seen that the position was going laterally as well as the cranially in the proper direction. So this is what it will look like after a multi-segmental fixation. And this is the, as you can see, the screw is going lateral. This is the vertebratory foramen. So the screw, as we said, is going lateral and cranial. And this is parallel to the facet joint. So in case of problem, actually, though it is not in the purview of this course, just a brief 2-3 slides about cervical pedicle screws. In case of problem, if there is a cervical lateral mass breakage, you can skip one level, go to the other level. That is the best way. In case it's a deformity, and actually if you require a big biomechanical anchors, means the strength should be better, then pedicle screws are also utilized. But however, it requires experience, and the pedicle is quite narrow in the cervical region, as well as the artery, the vertebral artery is quite close, as we have seen in the axial cut that there is a small block of bone and the vertebral artery just in front of it. So with experience, obviously you have to do that. And if you have the facility for navigation, then it's better. Those C7 pedicle screws are can be safely put because there is no vertebral artery. But rest of the screws usually requires a bit of experience. And above C5 means the C3, C4, C5 people usually prefer it to do it with navigation. So, but the technique remains the same. As I said that the entry point will be lateral compared to the thoracic, compared to the lateral mass, and the medial trajectory will be quite medial. So it will be almost 40 to 45 degree of angulation medially. And this is what is described by Dr. Abumi, the funnel technique. When you remove the cortex, you just do with a small dissector, you just take out the cancellous bone, so that will give way to the pedicle. So this is actually the funnel technique as it described originally. And the entry point is, again, the entry point here, we have to define the facet joint above and do a central line, the vertical line dividing this facet joint into two parts. The entry point is around 1 to 2 millimeter below and lateral, not medial, because here just below the facet joint and lateral is the entry point. The trajectory, the mediolateral trajectory, we already said it's around 45 degrees. And the craniocaudal trajectory is actually decided by a C-arm. So this is what the funnel technique, you just burr it and do a bit of cancellous bone removal, and that will give way to the pedicle. And this is how it should be put. The craniocaudal trajectory will be decided by the your C-arm, which will guide you, or the navigation if you have the facility. So then it's same like the other pedicle screws elsewhere. You do the probing, you do the sound and everything, and then put a screw. And this is how it is done. But to be in the beginning of your practice, it is better to master lateral mass 1-1-20-20. And I think you, as you graduate more into your experience, then you can then try this lateral mass and all those things, the pedicle and other things. Thank you very much for your kind attention. I hope after this you will be able to put it successfully. Thank you.
Thanks, Sachin.